It is my pleasure to be able to share some thoughts with you at the conference. I wish I could be there in person. I'm really happy to hear that you're meeting again, and I hope that what I have to share will add value. Again, not being present there, I would get a lot of value from the things that you're sharing and talking about. But my background is physical therapy, and I have worked with children with special needs for my whole career. So I came into the idea of palliative care from not so much from children that have life-threatening conditions, but children that have life-altering conditions. And so what I hope to share with you a little bit today is some of the types of disabilities and conditions that we see in children, and how the idea of palliative care works with those children and their families. I hope to help you be able to understand some of the differences, appreciate the similarities and differences in working with families with these two different types of conditions, and empathize with families who are faced with very long-term or lifetime conditions, as opposed to maybe shorter-term life-threatening conditions. So just as we start, again, I would love this to be more interactive, but to think about, what is your experience with people with special needs? What were you taught as a child? We know that the way we see people who are different from us is based on what we were taught as children or comfortable with. Were you taught to stay away from them, not touch them, not look at them, that maybe their condition's contagious? Think about maybe what names you have in your mother tongue for people with special needs, for things like people who are blind or deaf or mute or lame or drool. These are all things that could describe the people that I've worked with for years. Have you ever known someone or a family personally that was impacted by disability? And if so, what was their experience? Just because you may receive some training in your training programs or in an in-service of how to serve people with special needs does not mean it will be easy or comfortable for you. So as we begin, I'd like you to think about what fears you might not have now or about the future. And this is very just human nature to feel uncomfortable with this. Palliative care in situations where children have lifelong disabling conditions may require kind of long-term management and may have different goals than a situation where a child has a very life-threatening condition. The discussions aren't necessarily going to be around end of life, but goals for maximizing a child's enjoyment of life and make the most of his or her time spent with family. Such discussions may help families define goals and assess treatment recommendations, and even make decisions about some possible treatments. It's not the idea of giving up on treatment, but providing support to the whole family. And as you all know, I'm kind of preaching to the choir here, often involves siblings who are impacted when another child in the family has a disability. From a theological foundation, in the body of Christ or other religious communities, all people are needed, both the strong and the weak. But people with disabilities or parents of children who have disabilities or special needs often feel abandoned by their families, their faith communities, and by God Himself. And we have the opportunity by our interactions with them to speak hope to them. A word, just because we're in Uganda and the refugee population, refugees with disabilities tend to be among the most isolated, socially excluded, and marginalized of all displaced populations. I've been told when I've visited some of the refugee settlements that people with disabilities may not even make it. They may need to be abandoned as families flee conflict or disaster because of the physical limitations or difficulties. And when they are taken along, then they and their families may face additional discrimination at the shelters, have difficulty getting food rations, and things like that. So as we begin, I'd like you to think of what types of disabilities or people with disabilities have you seen in your work and your life? Some of the more common ones are polio, trauma, burns, cerebral palsy, spina bifida, and hydrocephalus. And to take a few of these one at a time. Cerebral palsy, and I have to admit, this is one of my clinical loves, so I could talk a long time on this, but cerebral palsy is a movement disorder that is based on or due to either abnormal development of the brain or damage to a part of the brain that controls movement, balance, posture. This could happen while a baby's in the womb developing. It could happen at the time the baby's being born or shortly after birth up to a couple years. Children with cerebral palsy may also have problems with hearing, with seeing, with feeling and understanding their world. About a third of them may also have the difficulty with the ability to think or reason and have seizures, but many of them don't. And that's a false assumption that we make, or when we treat them as if they're not understanding. The photos here are of a young man that was seen, and people thought he was just sort of faking his disability to get something, to get food, to get handouts. And when someone realized, I think he might just have cerebral palsy and he might not be able to speak to us, but let's help him get some fresh clothes and bathed and bring him into the church and greet him warmly. And another thing about cerebral palsy is the injury that's occurred in the brain doesn't usually change. So it's not like that area of injury to the brain is going to get worse, although the symptoms may. So what you look like when you're 2 with it will look different than when you're 12 or when you're 22. Spina bifida is another common disability that we see, and that's a neural tube defect. So when a baby is developing in the womb, often very, very early in the pregnancy, almost before mom knows she's pregnant, the spinal cord or the spinal column fails to develop correctly. So that, as we know, the spinal column is the bony protection of the spinal cord and where the spinal nerves originate. And when that develops improperly, or there's a hole, so to speak, the spinal cord can actually protrude outside that part of the back. The most severe form is called myelomeningocele, and that's where the spinal column, the spinal cord and the coverings for it are actually born outside of the body. So if you've ever seen that or seen pictures of it, the child will have a big sac on their back and needs to be operated on very quickly because it's very vulnerable to that sac rupturing and or infection or damage that would cause even more problems. Some things that are associated with spina bifida could be attention and learning disorders, bone or muscle problems, because it's basically like a spinal cord injury, but a less clean cut. And so some muscles work and some muscles don't. And there's often associated hydrocephalus, but not always. Usually decreased feeling and sensation. So you can see this little girl, if she's moving herself around on her compound and not feeling her feet, she could get wounds on her feet or her legs. Often there's difficulty with standing and walking due to weakness and muscle imbalance. And then that type of inactivity can lead to weight gain. Hydrocephalus, as you know, occurs when there's too much cerebrospinal fluid or CSF building up in the ventricles of the brain. And it could be because there's overproduction of CSF. It could be because the absorption or the processing of it is not working properly. And we don't always necessarily know, but when a child's head becomes big, like the one in the right-hand side, in the right picture, uh, the skull will grow, but also there's swelling internally. And so there's a lot of increased pressure on the brain, which can give a child headaches, make them feel uncomfortable, and just do damage to the normal healthy brain tissue. And in Uganda, we see very many cases of hydrocephalus due to infection. When I help sometimes doing wheelchairs, we often will meet children who have heads that are so big, we're only able to really put them in a wheelchair if it can fully recline, and we make them sort of a bed on wheels because their head is too large and too heavy to sit up with. Spinal cord injuries. There are so many different types of spinal cord injuries or positions, and spinal cord injuries affect all people differently, depending on the location and the severity of the injury. So, injury at the level of the neck will cause paralysis in both arms and legs. And if it's high enough, it may even make breathing without a ventilator impossible. An injury lower on the spinal cord may only affect the lower legs, like the young man on the left, who was a very tall young man. It was difficult to find a wheelchair that fit him well. Um, Spinal cord injuries can be complete, where there's a complete lack of motor control, movement, and feeling below the level of the injury, or it may be incomplete. Other complications are loss of the ability to feel heat, cold, or touch, loss of bowel and bladder control, difficulty breathing or clearing secretions from the lungs when you get sick, difficulty swallowing, changes in sexual function and fertility. So spinal cord injuries can be very debilitating at whatever age the injury happens. There's also many people that we see with brain injury and many possible causes of brain injury. One is a stroke. Another would be a prolonged, either a decreased flow of oxygen, so a hypoxic injury, or an actual lack of oxygen leading to an anoxic brain injury. And this can happen again when a child is being born, or other times, if a child's choking, if yeah, and any number of things that can, whenever the brain is depleted or deprived of oxygen, it becomes injured. Also, injury can happen due to encephalitis or meningitis. So an infectious type of thing where the brain is impacted, brain tumors, trauma caused when the head is hit hard, or if the head is whipped violently, if the neck is whipped around. And it could be more mild, something like a concussion, or it can be much more severe and debilitating. Traumatic brain injuries are among the most common types of injuries, and again, can be anything from a concussion, which can happen playing a sport, falling and knocking your head, um, and many other types of neurotraumas. For children and teens, we can see things like children taking falls, certainly being hit by a car or being on a boda that's hit, sometimes contact sports such as football, risky behaviors such as skating behind a taxi or different things. So many different things can cause brain injuries. And usually these injuries are permanent. Epilepsy, which or other seizures, or called fits or convulsions. And as you know, our brains have constant electrical activity in and between the cells. And a seizure is an abnormal electrical discharge in brain cells that cause a change in the normal activity, behavior, or movement. So when families are trying to understand a seizure and what that's like and what causes it or what the impact might be on the brain, I try to explain it's sort of like when we have a power outage or a power surge. So when the electrical impulses are either stopped or cut off for some reason, or are too much, it can cause a damage to the brain cells, and the brain just can't work the way it's supposed to when the electrical activity is coming and going. And so that seems to be helpful for families to understand what might be happening in their child's brain. After a seizure, a child or an adult may fall asleep, may not remember what happened. They may move very abnormally when it's happening, and it can be very scary for everyone. There's another whole set of diseases which are considered, fall under the category of neuromuscular diseases or conditions. And these are ones that typically affect the peripheral nerves. So not the brain and the spinal cord, like a brain injury or spina bifida, but more the extremities, the skeletal muscles, those of the trunk, the arms, and the legs. These conditions can be static and unchanging, but often they're progressive, meaning they grow worse over time. Many are present at birth, many have a genetic component and can affect multiple generations in a family. There are hundreds of neuromuscular conditions, and sometimes we, may only ever see one of them in our whole careers. And although that sometimes their conditions look similar and there's some similar treatments, there also are some unique treatment strategies depending on the particular condition. One of the more common is muscular dystrophy. Is Duchenne muscular dystrophy, which is a recessive, it's on the X chromosome, it's present at birth, but usually the symptoms don't come up until the child, this boy, it's primarily in boys, will start tripping and falling and having trouble climbing steps, or the speed of their movement slows down. And this is one that does get progressively worse. And often young men with muscular dystrophy may die in their late teens or 20s from respiratory failure. Limb loss could be congenital, meaning someone's born with a missing limb or a part of a missing limb, or acquired, that it happens sometime later in life. A congenital limb deficiency can involve the upper or the lower limb, or sometimes multiple limbs. But more often, maybe just a portion of the limb is missing, or the remaining portion doesn't form normally. And then acquired amputations can be the result of cancer. If there's a tumor in a limb and it needs to be resected, cut off, trauma, of course, or severe infections. So there's many examples of limb loss, and fortunately, we're able to try to find some adaptations for people with limb loss to go to school and do other meaningful things in life. Some of them I've shared with you more, some of the motor impairments. I'm a physiotherapist and tend to work with children with motor impairments, but also there are a number of intellectual impairments, and I overlap with other colleagues who have much more expertise in these. A few of these are Down syndrome, which I'm sure, as you know, is a chromosome abnormality, trisomy 21. Some of you, if you're there, work with heart patients. You may have dealt with children with Down syndrome because they may also have associated cardiac conditions. They often have delayed milestones and cognitive impairment. They often have low muscle tone, meaning their ability to move their muscles is challenging. They may be small. They have a characteristic 1 instead of 2 crease in their palm, and their faces often look similar to this young man. I'm always amazed how people with Down syndrome also often have similarities to other people with Down syndrome, but also look like people in their family. Autism and autism spectrum disorder, there is a very broad range for people who fall into this disorder. It usually involves impaired communication and social interaction, maybe combined with rigid, repetitive type behaviors. The boy on the left here has autism, and he actually is being restrained right in his home for his own safety. His father has a disability, and if this young man chooses to run, he's unsafe. And so neighbors in their community help kind of keep him close in the community and help his father love him and take care of him. Often people with autism aren't able to communicate what they're thinking or desiring. And we find out that often they do have ideas or things they want. And they also have difficulty understanding what other people might be thinking. So, as you know, so much of our communication is based on nonverbals and reading facial expressions and things. And often people with autism really struggle with that. So that's all the specifics that I wanted to talk about for conditions, but just some general things as you may interact more differently with people with lifetime special needs is we try to use people first language so that you would say the young boy with cerebral palsy as opposed to the CP boy or the mama who had polio when she was young. So we try to define the person and his or her dignity before just calling out the impairment or the disability. And what happens actually is typically people have impairments, which the man on the bottom picture, he did have polio as a young man, and he was able to have a hand cycle, and he's married and has a family. So he has impairments, but because he's had some adaptations and some adaptive equipment, he doesn't have the same level of disability that he would if he was still crawling on the ground. So disability comes more from the environment and things than what's within the person. Just I'm sure you all know that, the United Nations Convention, things on children, but on the rights of people with disabilities, again, to affirm the dignity and human rights of all people with disabilities, that people with disabilities would have equal access and full enjoyment of all human rights. And those principles include inherent dignity, non-discrimination, effective inclusion, different respect for their differences, equal opportunities for children. That means equal opportunities to education, which is often a big challenge, accessibility, and respect for the evolving capacities of children with disabilities. A sad truth is that people with disabilities usually are at increased risk for violence. Adults with disabilities, especially adults with intellectual disabilities, kind of are at risk for abuse, neglect, other forms of violence. Children are 3 to 4 times more likely to be victims of violence. And just the thing that because they're dependent and they have needs for caregiving and things, puts them in a vulnerable position, and we need to be aware of that. Also, then, what do we need to do? I find that for me, although I've done this for decades, I need to take care of my own self and deal with the fact that we work with very hard things and we don't have answers to all of these. And I, over the last few years, have really been learning how to lament as a way to deal with sad emotions. I give myself permission to acknowledge the work is hard. I cry out to the Lord and even sometimes complain to God. Psalm 13 is a very great example of that, where the psalmist at the beginning starts out with, "How long, O Lord, will you forget me forever? How long will you hide your face from me? How long must I have sorrow in my heart all day?" So the expression of grief and sorrow over the situation that the child or the family is dealing with. And then coming back around and saying, "But you are good, Lord. I trust in your steadfast love. My heart shall rejoice in your salvation. I will sing to the Lord because you have dealt bountifully with me. So this is one of the things that I've learned to do as a healthcare worker, but actually it has also allowed me to reach out to parents and encourage parents of children with special needs to lament when they need to as well. Grief when you have a child that has a lifelong disability can be very cyclical and come and go. And I have found in working with families that the ones who seem to do the best are the ones that acknowledge their grief when it comes and give themselves permission to grieve, and then find back to their baseline and go back to rejoicing and enjoying their lives. And we need to remember that we aren't going to be able to solve all these hard things or answer all these hard questions. And many of the families with children with disabilities, it is a lifelong experience. So, just to end here, my encouragement to you is to ask yourself what's next. For you personally, are there things that you've learned here or heard here that connect with things that you've done in your work that you want to kind of explore more, whether it's a particular condition or how um, lifelong conditions bring about a special type of dealing with things or searching through things? What about for your team? Are you on a team where you can discuss these things, where you can freely come and say things are hard and we need to talk about it, or I need support, I'm struggling with this? And what might be next for the children and families with whom you work, based on the fact that you're doing this training for a few days and you've had a small opportunity to see into perhaps a different type of condition where your expertise and knowledge of palliative care can be a contribution. Thank you so much for this opportunity to share with you. And if you would have any questions, I would welcome interaction, and I wish you all the best. Thank you.